of guided implant therapy. So just a little bit about myself. Originally, I was born in Sydney, where I did my initial undergraduate training. After I graduated, I moved to the Gold Coast, where I worked for a number of years as a general dentist, before finally moving to Brisbane, where I completed my specialist training in periodontics, and where I'm now working as a periodontist and associate lecturer at the University of Queensland. So guided surgery has become a mainstay of implant therapy. And we see that it's been increasingly adopted by clinicians. This has been partially fueled by reports of superior accuracy in recent randomized controlled trials when compared to freehand surgery. Furthermore, there have been reports of improved satisfaction, patient satisfaction with the use of guided surgery. In a recent randomized controlled trial by Sancho Pichardis, 83% of patients who received guided surgery were satisfied with their group allocation, as opposed to 50% of patients who received freehand surgery. And this difference remains significant even after the surgery was performed. But do clinicians and patients truly understand the benefits of guided surgery? And is guided surgery suitable for every implant case? I'll be addressing these questions throughout my presentation. So just an overview of what I'll be covering. Initially, I'll talk a little bit about guided surgery and the different types of guided surgery, before talking about potential benefits beyond improved accuracy, before finally finishing with my case presentation. So guided surgery or computer-assisted implant surgery can generally be divided into three main subcategories. Cast-based guided surgery, and this is the conventional way that guided surgery was performed, where the surgical stent was manufactured from the dental cast. The guide was non-restrictive in nature, allowing changes in angulations and position during the surgery. The second type of guided surgery is static guides, and this utilizes a stereolithographic surgical template, where the positioning and angulation is all predetermined prior to the surgery, and consequently the guide is restrictive in nature. And finally, dynamic guides, which utilizes virtual real-time guidance, where the position is dynamically illustrated on CBCT data and fed back to the operator via monitor, allowing intraoperative changes. So for my presentation, I'll be mainly focusing on static guides and to the literature specific on partially dentate cases. So there have been a large number of studies which have looked at potential factors which can affect the accuracy of guided surgery. And what I mean by accuracy is how well the final position of the implant in the patient's mouth matches that in the implant planning software. So these factors can generally be divided for static guides into four main groups. Factors related to the image acquisition and data processing, to the design and the manufacture of the surgical stent, factors related to the use during surgery, such as anatomical limitations, and then those related to implant design and site factors. So we can see there's a large number of factors that ultimately can influence the final accuracy of the implant surgery. And consequently, careful case selection and considered guide design is paramount to optimizing the treatment outcome. I'll now talk a little bit about the potential benefits beyond improved accuracy. So as already mentioned, improved accuracy of guided surgery beyond freehand surgery has been demonstrated in a number of recent randomized control trials, and this is summarized well in a recent systematic review by Tatan et al. In 2020, which showed that there was significantly lower angular, coronal, and apical deviations compared to freehand surgery. However, despite this improvement in accuracy, will your patient thank you for your decision to use guided surgery? And what I mean by that is, does static guides or guided surgery facilitate superior clinical outcomes by reducing failures, complications, and adverse effects? A number of studies have evaluated these endpoints of guides, looking at different success outcomes and complications, such as early failure or biological complications, as well as a myriad of patient-reported outcome measures. To date, however, there's insufficient evidence to support a benefit in any of these outcomes with the use of guided surgery. This is supported by a recent randomized control trial, which compared static guides with conventional implant surgery, and despite controlling for the number of implants placed in each patient and the position of the implant, there were no significant differences in the evaluated patient-reported outcome measures. And again, this is supported by no significant difference is supported by a recent systematic review that even after evaluating the available evidence, failed to show significant differences between CAIS or freehand protocols. Okay, so I'll now finish with my case presentation. So this patient is a 73-year-old female who presented complaining of poor aesthetics related to her upper partial denture, as well as poor aesthetics of her upper anterior teeth. A little bit of background about the case. Initially, she had multiple extractions performed due to caries back in 1990. She then subsequently had extensive crown and bridge work performed, which failed prior to her presenting to me for consultation in 2022. The patient has hypertension as well as hypercholesteremia. In terms of her dental history, unfortunately, she was an irregular dental attender. She did report brushing 3 times a day and flossing daily. However, on intraoral examination, there was inadequate oral hygiene around her upper third molars. The patient is also a non-smoker. This is the patient's OPG. At the time of presentation, the bridges in quadrant 2 and 4 had been sectioned, and the tooth 4-4 was a retained root, as we can see in these clinical photographs. Periodontally, the patient had deep probing pocket depths associated with the teeth 1-8 and 2-8, and there was also attachment loss and loss of interdental papilla between most of her anterior teeth. So we diagnosed the patient as having unesthetic anterior crowns resulting from discrepancy in color between teeth, unnatural tooth proportions and contours. She also had a loss of posterior support and unesthetic denture. We classified her as having stage 4 localized grade B periodontitis and a 4-4 retained root, which was unrestorable. So in addressing the patient's primary complaint, the 2 main treatment options that we had available to address her denture were to either provide her implant-supported removable partial denture, which would have resulted in superior cleansability compared to a completely fixed option, as well as reduced cost, or alternatively, a complete fixed option, which we envisioned would take the form of 2 implant-supported bridges in the maxilla, a mesial cantilever bridge in quadrant 4, and then a single unit implant to support a single unit crown in the 3-6 site. This option was the patient's preference, and despite increased cost, treatment time, and likely morbidity, the patient opted to proceed with the fixed implant option. So we initially provided treatment for the periodontitis, providing the patient oral hygiene instruction and subgingival instrumentation, as well as extraction of the 4-4 retained root. We then evaluated the patient 3 months after and noted that the patient had achieved periodontal stability. Consequently, we were free to proceed with the implant therapy, knowing that we had controlled the risk factors for periimplantitis. So this is the prosthetically driven treatment planning for the maxilla. We were looking to place 4 bone-level Straumann implants to support 2 implant support bridges, noting that there was reduced bone on the buccal aspect of the 1-4 site, which could have potentially necessitated guided bone regeneration at the time of surgery. This is the prosthetic plan for the mandible, where we plan to place 2 tissue-level implants, one to support a cantilever bridge in the 4-6 site, and one to support a single unit crown in the 3-6 site. So these were the surgical guides which we plan to use at the time of surgery. In terms of considerations in their design, we ensured that both of the guides were supported with at least 4 teeth, with a minimal drilling distance between the guide sleeve and the bone crest. We also had verification windows made evenly distributed throughout the guide to ensure that we could confirm seating at the time of surgery. We felt that a guided approach was suitable for the maxilla, as a recent randomized control trial has shown superior accuracy and parallelism could be achieved with a guided approach as opposed to freehand surgery, and the accuracy was also further lent to by the fact that the implant sites were healed sites as opposed to extraction sockets. In the mandible, we opted for a partially guided implant surgery approach. Reason being is that the wide soft tissue collars of the implants would not have allowed us to place the implants through the surgical guide. At the time of surgery, however, despite all these considerations, the maxillary guide exhibited insufficient fit, and consequently we weren't able to use this guide during the surgery. So why didn't the guide fit? So factors affecting the guide fit has been seldom investigated, as noted in a recent systematic review by Thomas-Ebb 2018. However, one of the factors which may have contributed to the poor fit in this case was our decision to use the extraoral scan of the dental model as opposed to an intraoral scan of the patient to design the guide off. A recent randomized control trial has compared these 2 modalities of scanning, but found no significant differences in accuracy between the groups. The study, however, did note that errors could be introduced during the analog to digital conversion models, resulting in incorrect proportions. So we decided as an academic exercise to retrospectively evaluate the potential reasons for the poor fit in this case. So what we did was perform an intraoral scan of the patient's mouth after the surgery was performed and superimpose the two models using the Geomagic software and their best fit algorithm. And what we noted was there was significant deviation in the on the palatal aspect of the 223, upwards of 1 millimeter, which would have significantly affected the fit of the guide. And we can see this as well on the digital planning on co-diagnostics. So what this shows us ultimately is that errors can be introduced at any step during the SKICE workflow. And each record should be taken as carefully and accurately as possible to minimize errors. Thankfully, we had anticipated potential problems with the SKICE guide and had manufactured a cast-based guide as well during the time of surgery. And these are the photos of us using that guide. This is a photo of the suturing at the time of surgery and a photo of 2 weeks post-operatively. Again, this is the photo of the surgery for the quadrant 2 bridge, suturing, and at 2 weeks post-op. These were the radiographs taken at the time of surgery. Thankfully, we were able to proceed with the partially guided approach, which we initially planned in the mandible. This is the implant in quadrant 3 and the implant in quadrant 4 supporting the mesial cantilever bridge. These were the images taken at the second stage surgery and at case completion. So just for completeness, we also, these are just the photos of the patient at consultation and as well at case completion. We were also able to perform a 1-year follow-up. So again, this is at case completion and at the photos at the 1-year follow-up. And thankfully, at the 1-year follow-up, the patient reported no complications with the implants or the inserted prostheses. And again, these are the radiographs taken at case completion and at the 1-year follow-up. Okay, so in conclusion, the accuracy of static CICE has been demonstrated, but is not free from errors. And current guidelines recommend a 2 millimeter safety margin when planning guided cases. And because there's the potential for error, proper case selection, careful planning, and considered guide design is paramount to optimizing treatment success. And finally, despite a superiority or superior accuracy being demonstrated, potentially mainly in straightforward cases, there is little direct evidence currently to support reduced complications, improved success, and patient-reported outcome measures with the use of static CICE. Thank you.
Recording stopped.
Okay, thank you for your presentation. So, judges, any comments, any requests?
Sure, I'll go first. It was very well put together. I think you have an excellent flow as well in your demeanor, so congratulations. The one thing I'd like to clarify in the presentation and hopefully in future as you progress is to differentiate the differences between the success rates on guided surgery on edentulous versus non-edentulous, as you did in the partial edentulous here, as you were focusing here, and to try to break that down a little bit further as maybe certain reasons that the guide doesn't fit when there is, for example, teeth, as you suggested when you did the comparison in Geomagic between the scan model versus the intraoral scan, and to try to break that down just a little bit more to clarify in the beginning of the presentation. I think you did an excellent job showing the research amount that you were looking to try to convey and ultimately reach your point, and completed a difficult surgery. It's always nice to see that people can go free-handed when necessary, or not free-handed, but I would say more template assisted, which is the method that you ended up choosing. And ultimately the result was great for the patient regardless, because you took your care, which is obviously our ultimate goal in dentistry. So if you just clarify at one point in the beginning of the presentation, I think that would kind of really complete the presentation.
Cheers, thank you.
So very nicely done.
Thank you.
Yes, congratulations also for the presentation. It was very ordered at the beginning, and the case is interesting. And also, well, you know, the thing about the fit of the guide is a thing that we have to try before before the surgery. And but congratulations, it's a very nice presentation, and thank you for showing us your presentation.
Cheers. Thank you.
Good evening, ladies and gentlemen, MINEC team, and I think the fellow judges, Dr. Tawe and Consuela, is good morning to you all, yeah, and good afternoon to the rest of the world who is following this live streaming of this continental round of MEGA'MIND Contest 2024. So actually, I'm in the second year in a row in this continental round. I'm Dr. Wan Leong from Malaysia. I'm proud to represent Asia League in this continental round. So this year, I hope I can make it one step further, that I can go to the final rounds in Cannes, France. Pray hard and I do my best. Yeah, let's go. Okay, so this year I'm going to share with you the tunneling GBR with one incision for anterior thin ridge. So I learned this Vista technique from this Professor Homa himself in 2012 in IDEM, Singapore. Then in 10 years later, in 2022, I refreshed this course again with Professor Homa himself again. So this technique is called Vista technique. It's a vestibular incision, subperiosteal tunneling access. It's just a tunneling that we're going to do for GBR. Yeah. So there are many research papers regarding this Vista technique to treat gingival recession since 2011 until right now. But today I'm going to share with you how to use this Vista incision to do GBR for our treatment planning of our implant patient. Let me introduce to you my implant patient first. This is Miss Ang, 41-year-old lady. There's field 1-1 and 1-3 bridge and 2-1 to 2-3 bridge. And the patient is complaining of very sensitive to hot and cold. Even when she opens her mouth and the aircon from the car is spraying on the mouth, she feel very, very sensitive. And this is after we have removed the old bridge from the patients, the 1-1 and 1-3, the apartment, we have a lot of recurrent caries over there. And after serious thought and decision making with the patients decided to do a new bridge on 1-1 to 1-3, and new crowns on 2-1 and 2-3 after root canal treatment and post, and another new implant crowns on 2-2. So you can see the hollowing effect of the early loss of the lateral incisors, and you have this black shadow around there because of the knife edge reach of the resorption over there. And let me show you a video how to do this Vista technique. So at first we give local anesthetic to the patient first, and you do a vestibular incision, small incision until the mucogingival junction, and we use this Professor Homa's tunneling instrument which has various angles and sizes that we can tunnel through. So for our target area today is the 2-2 area. So we decided to tunnel from the 1 tooth in front of the target area, that means 2-1, and 1 tooth posterior to the 2-2 area. That means we tunnel from 2-1 to 2-3, so that we can tunnel it nicely and we can condense our bone graft in very nicely. Let me fast forward the video a bit. So we have this bigger one, that is straight one, that we can go until the 2-3 area. All right. So this technique is vestibular incision, subperiosteal tunneling access. That means we don't do partial thickness, it's the full thickness flap that preserves the blood supply and minimize the graft exposure later, because we just do a small incision over there. And I use this bone graft condenser or carrier to put the allograft furos into the tunneling access we have created. I put around 0.75 cc, condense it nicely. As you all know, allograft, there are two processes of sterilization. One is freeze-dried, and another one is solvent dehydration process. And I like to use this Puros Filtoplast solvent dehydration process because after sterilization of this Puros allograft, we still maintain its osteoinduction potential. That means you stimulate osteogenesis. So we try to condense it nicely using the Homa tunneling instrument to condense it to the target area where there is two knife reach area. This is the comparison of before and after. You can see that the hollowing of the lateral incisor 1-2 and 2-2. We are going to do the tunneling. It is immediate post-op. You can see that the black shadow of the hollow over there has already diminished because of the bulging of the graft that we put inside the tunneling that we have created. So there's no more dark shadow over there. Let's go through the CBCT before the tunneling GBR that we have done. So you can see the knife reach over there because of the resorption of the early loss of the lateral incisor, the 2-2. There's only 1.37 of horizontal width. This is what we got after the Vista GBR. We got about around 6.71 mm at the apical area, and the horizontal width at the occlusal is 5 mm that we got. But no matter what we do for the patient, we can build a hill or a mountain or a house for the patient at the deficient site. But at the end of the day, biology rules. This is 6 months later that we have anticipated that there will be some resorption that we just left with 4 mm of horizontal width. So never supersede biology. Biology is the top priority that we need. So this is before implant insertion after 6 months. And we plan our implant surgery using guided surgery. So we plan prosthetically driven with cingulum placement so that we got a screw retained crown later to prevent cement remnants that can cause peri-implantitis in the future. And we plan this case using AnyRich Mini 3 mm by 11.5 mm length. And you can see where we can anticipate that there will be some thread exposed at the palatal area. And this is the surgical guide that we have used. And this is a short video to show you that the collection of the autogenous bone with the pilot drill, we use pumping motion to lessen the kick that can cause the bone death. So we up and down motion slowly with plenty of irrigation. And we can collect a lot of autogenous bone core from the special drill. So this bone core that we have selected, we do as a first layer of graft material that is connecting with the surface of the implant. So this is the implant insertion. Before we put in the implant, we use plasma X motion to photo-functionalize and sterilize the implant. And you can see that it increases the hydrophilicity of the implant. Before we insert in, the blood will be sucked onto the surface of the implant very nicely and to increase osseointegration and cell adhesion. This intraoral photograph of this is to make sure that we have our crystal level of the implant, the 4 mm rule. The depth of the implant, we control it from 4 mm from the future gingival zenith of the implant restoration. Alright? And we got a very good insertion torque of 35 Newton centimeter. As you can see from this short video, I put a membrane on the palatal side because when we plan the guided surgery, we know that there will be some thread exposed over there. And we try to use the first layer autogenous graft that we have selected from the R2 guided drill. And we put it in the palatal area that is touching the implant surface so that it will be more osteogenesis. The membrane there is to prevent the epithelium from going in before the bone ossifies itself. Then we use second grafting of the purus allograft, the solvent dehydration allograft. We pack in nicely. I use around 0.75 cc of the purus allograft. Pack in nicely. Don't condense the bone graft like you're condensing the amalgam. No void. This one we have loosely packed so the angiogenesis blood vessel can go in. So in order to increase the buccal soft tissue of this implant area, I use this special O6 Volumex, which is a sugar crosslink ossifying scaffold, which continues to ossify after it's resolved and increase the soft tissue thickness of the implant's soft tissue, buccal soft tissue over here. And we follow the lasso suture introduced by Professor Rodrigo Niva from University of Pennsylvania to hold this O6 Volumex and the palatal membrane and the graft nicely there, so that the graft stays there. We follow the past principles by Professor Hom Lei Wang from 2006. That is primary closure of the wound, angiogenesis, space maintenance, and stability of the wound. We don't want the graft to move around, so we use this lasso suture to hold it nicely, and we use modified horizontal mattress suture for primary closure to get a very good stability of the implants. This is the immediate post-op of the CBCT with the allograft puros over there. And this is 5 months later, before we put in the healing abutment. So we take again the CBCT, the graft is still very stable at the buccal, and we use papilla preservation roll flap to put in our healing abutment. That means you don't incise on the papilla area, and we roll in the flap nicely to increase the buccal soft tissue again for the supracrestal complex to be very nice. And this is the photo to show you that we plan it cingulum placement to make sure that this very cingulum placement to reduce the cement remnant later. We do the screw retain implant crown. And this is a short video to show you how rock solid the osseointegration are from the allograft that we use during the tunnel access. So the osseointegration is very rock solid. And this is 1 month later. What I'm going to do is that I'm going to remove the pontic of the temporary bridge, and I use the temporary crown shell with throwables, manually, analog with a jig ring. All right. To make sure that it's fitted nicely, before we put into the mouth to try again the temporary shell with the jig ring on the 2.1 and 2.3 temporary crowns. Make sure that it's fit nicely, and we bond it to the temporary abutment. Bond it to the temporary abutment, make sure that everything is perfect to mold the gingival tissue very nicely, and then we trim away the jig wing. This is the shape of the temporary abutment that we're going to put into the patient's mouth, and after we screw it in, we take a periapical to make sure that the fitting is very nicely, and we try to follow Professor Dennis Tarnow's 5 mm rule from 1993. That means the distance between the contact point to the crestal bone level, if it's less than 5, Professor Dennis Tarnow said that the papilla will fill up the space interdentally around 100% of the time. Okay, so we try to make sure that the gingival level is the same with the contralateral side with the gingival molding of this temporary crown. This is 1 month later after the gingival molding. We add pouch of composite on the buccal and mesiodistal for the papilla fill. Make sure that the gingival height is the same. And this is 3 months later after the gingival molding. You can see that the supracrestal complex is very healthy and nice with all the tunneling access and the roll flap and the O6 volume max. And all our implant counts, we use scan abutment digital impression. And this is the CAD design that comes back from the lab that we can discuss with them what type is when we use the contact point, the shape of the implants, whatever it is, you discuss with the technician. That is very important for the success of our implant therapy. And this is the final product that is come back from the lab. So you can see that it's screw retained with the emergence profile that follow the molding of the emergence profile that we have done using the temporary. And this is the plasma exmotion again that we first functionalize for better cell adhesion of the immediate the permanent restoration. You can see that the plasma ray is shooting onto the abutments and you can sterilize the zirconia that we're going to screw in for the patients. So this is the final result. You can see that we try to achieve the same level of gingival height. This is the 3-unit bridge on 1-1 to 1-3, and this is the crown. This is the 2-3 crowns, and this is the implant crowns screw retain. All right. So this is another close-up view, and let me show you that there's no graft at the hollow side at the 1-2. You can see that the hollow is still there, the bridge. And this is the side that's tunneling bulge that we have done using the Vista GBR and the O6 volume max, plus the roll flap that we do to create the healing abutment when you put in the healing abutment. And this is a close-up view of the supracrestal complex that you can see that the supracrestal complex, the gingiva is so firm and tight and very nice with a healthy shape that we can screw in our screw retain crown. This is immediately post-op that you can see the screw retain crowns screwing in, and this is the crowns, and this is the bridge. And you can compare that without the GBR, is hollowing effect with the dark shadow over there. This is the bulging effect, tunneling effect that we've done for the patients. Comparison before and after. This is the removal of the bridge already, old bridge. And this is the permanent bridge 3-unit. And this is the temporary bridge. This is before the implant placement. This is after the implant placement. This is with the first temporary that we do to mold the gingival profile. And this is the second temporary that we use to mold the gingival again for the emergence profile. This is the final result that we get. And again, the comparison before, and this is the removal. You can see the recurrent caries. There's so much. Before, the old bridge, very sensitive, and this is the final result that we get. So the take-home message that I want to give to everyone that is following this Zoom meeting, although this is not a perfect case, not 100%, don't give 100 marks to myself, but in my humble opinion, I think it's a great technique to build bone compared to conventional GBR. And it only involves one incision, low morbidity, no big flap, less suffering for patients, and preserve the blood supply because we don't do partial thickness flap, we sub-periosteal, we protect the periosteum and minimize the graft exposure because there's only one incision. And it's better healing of wound in Vista. And emergence profile molding of gingiva with temporary PMA is a must in anterior aesthetic case. No matter 2 or 3 temporary you do for the patient, you also must do for the patient's emergence profile. And O6 volume max is a very good and thick membrane with potential bone forming and increase the quantity and quality of the soft tissue. Thanks a lot for listening to my presentation. Thank you so much.
Recording stopped.
Okay, thank you for your presentation. So, judges, any comments?
Well, congratulations for your presentation. You had a lot of energy in your case, and it's really interesting. And thank you for the participation.
Thank you, Dr. Gonzalo.
Thank you. Nicely done. Difficult technique to showcase. I think you did a good job.
Yeah.
But I want to hear you, not the video from the presentation. If you can lower the volume from the videos so we can hear your amazing voice and what you were trying to convey over it. But you did a wonderful job. You had good presence, good cadence. So, and it's good seeing you virtually, but hopefully we see you in person soon.
Yeah, I'll meet you soon in New York.
I love that.
Yeah, that's
but
good.
Congratulations. Wonderful. Very, very nicely done.
Thank you so much. I think this one is very good for everyone because you don't have to use like a block bone graft or whatever from the donor side. And this technique is very useful, I think, to help a lot of people who is doing implant surgery so that we don't have to create a lot of big flap for the patients and have to take bone graft, a lot of bone graft. This is tunneling technique is very good, I think so. That's why I like to share this.
Nice.
Okay.
Wait, ah.
So you can start now.
Okay. I set my watch. Okay. Okay, I start now.
Okay.
Hello, I'm Neoh from Malaysia. Today, I'm going to present a small makeover case supported by implant using a stage approach. Wait,
Okay.
okay.
Any
My
problem?
slide cannot move.
Mm.
Wait,
Mm.
This is a 48 years old female. Her complaint is, Doc, my teeth are too small. She's obviously wearing a denture. So the next question is, we can make a new denture for you with a bigger teeth. But she said, no, I don't want denture anymore. I want implants. So yes, she's right. The lip is pretty retrusive, as can view more clearly from this view. And her teeth are unusually small. We did a digital smile design for her using her photo to see whether she'll look better with the bigger teeth. And using a computer simulation, we let her have a view first before we do any mock-up. And she's quite happy with the result. But is it possible? Do we need a porcelain gum So we transfer the teeth to her photo without the denture, and we discovered that we can possibly do our FP1 or FP2 bridge, but perhaps we need to make some porcelain papilla for her, because to augment papilla is not so easy, and she understands that. So actually the risk is pretty good, and obviously she has dental stomatitis from wearing the denture. And how thick is the ridge actually underneath the gum? The width, I think, is quite sufficient. But how about the width? Let's see. We took a CBCT, and obviously the ridge is pretty thin, about 2.5 to 3 millimeter. Is implant possible? Fortunately, at the back, the width are more, and the sinus are pretty clear. We can do some implant there, no problem. How about the lower ridge? There are some gaps due to the extracted premolar, and the teeth are drifted. So we discussed with the patient, why not we start to do implant at the lower jaw first after we consolidate the space. As the patient don't want any braces, we did the Invisalign aligner for her, and we managed to open up the space for a premolar. Yes, she's very happy with the result, and her initial slight phobia to implant has subsided. So we can proceed to the upper jaw, which is more complex. First, we make a wax-up denture for her to see whether she will look better with the bigger teeth, and also we want to test the aesthetic before we do anything. And we took some photo for her. Yes, yes. And we even do it for some studio shots. And she's very happy with the outcome. So we make a new denture. And from the CBCT, we know that we can place implant right away after some ridge augmentation and sinus lift. We place 4 implants at the posterior, and using densatria to do the crystal sinus lift with allograft, and also a little bit of lateral GPR. On the right-hand side, we close up the wound using PTFE suture, and the left-hand side, I did a buccal roll flap, and the denture was relieved. After 4 months, everything healed up quite nicely. And we exposed the 3 implants and installed the multi-unit abutment straight at the left-hand side and angulated at the left-hand side. So the denture was converted to an implant-supported provisional. After that, we perform lateral ridge augmentation using a VISTA method. What is VISTA? VISTA stands for vestibular incision subperiosteal tunnel approach, which was introduced by Dr. Muajade. Initially, it was used to augment the gingival recession. Then later, this method was used by doctors to do ridge augmentation, surgical exposure of impacted teeth, etc. In this case, we put allograft and collagen membrane into the incision to do the lateral ridge augmentation. And there's no pressure on the graft because we are using an implant-supported prosthesis as a provisional. So this method was well documented. And it was found that the tunnel technique is more cost-effective if we compare to open technique. According to this review paper as well, lateral access bone regeneration using a tunnel is, as compared with the open method, produce less postoperative discomfort, swelling, as well as complication. After 10 months, we wait for the graft to mature. Then we took an X-ray. The volume, although reduced a little bit, still more than sufficient for us to put in an implant. So 3 anterior implant was placed using a surgical guide supported by the implant, the posterior implant. And because we have a surgical guide, so everything is done precisely. There's no need for us to open a big flap. Also, the guide will provide for the punch exposure. So buccal minimal roll flap was performed. In this way, we can augment the soft tissue without a donor site. And the denture, the provisional denture was relieved, not to accept any pressure on the wound. Then this is the panel and the CPCT. After the wound was healed, we put on the multi-unit abutment and an implant-supported provisional was provided for the patient to assess everything, to assess the phonetic, the aesthetic, and to get the patient used to the provisional bridge. The patient was very happy with it. In fact, this went on for a few months. After everything, then we took the impression and copy everything into the CAD/CAM provisional. The technician produced the CAD/CAM provisional for the try-in. We put this on and let the patient try. The patient was very happy with it. After that, a zirconia bridge was provided. It was 2 sections, 5 unit and 2 unit, whereas the posterior were single crowns. Then everything was screw retained. The access cavity was patched up with composites. This is the before and after. Lip support was enhanced. Upon the 2-year review, everything is very stable. The patient was on the 3 months maintenance program. She's a very good patient. Everything is very stable, oral hygiene very good. And as we can see from the picture. She's wearing a nighttime mouth guard to protect to provide some protection and retention. Whereas the lower jaw, she's wearing a nighttime retainer as well. So in conclusion, stage approach can be beneficial when the situation are not ideal for us to place all the implant at once. And a few smaller procedures can be physically and psychologically less demanding for the patient and the team. And for some patients, we can less financially demanding as well, because the patient can pay as the treatment go by. And most minimal approach can be chosen in each stage. In this case, for the ridge augmentation, we use a Vista method. And then for the anterior implant, we can use the minimal flap to place the implant, because we are using a surgical guide supported by the already osseointegrated implant at the posterior. Another benefit is that it facilitates provisionalization. Patient can wear a fixed provisional instead of reverse partial denture, which is inconvenient and can exert pressure on the implant site, whereby it can affect the healing. So if you look at the literature, in fact, stage approach are not uncommon. Many people has been produced about this stage approach, either from the remote denture to a fixed restoration, or filling teeth to fixed restoration. So this is my the end of my presentation. Thank you.
Recording stopped.
Okay, thank you for your presentation.
Thank you.
So, judges, any comments?
Sure. I think it was nicely done. I think I thank you for presenting in English. I'm sure in your own language would be a lot easier for you, and you did a very good job conveying the message. So it's not an easy case that you picked either. It's quite difficult case that you picked, and it had a very nice result in the end. So congratulations to you.
Thank
Very
you.
nicely done.
Thank you.
Yes, I agree with Isaac. It's a very difficult case, and the results were fantastic. So congratulations, and thank you for your participation.
Thank you. Thank you.
Good morning. I'm Dr. Yang from Vietnam, and I'm pleased to meet you tonight. First of all, I would like to thank the judge and company for organizing the contact for me to share this clinical case. And before beginning with the slide, I would like to introduce a topic briefly. Okay. This topic today is single implant case, and I choose this case for two reasons. The first is implant. This is the implant immediate replacement. The second, I combine hard and soft tissue graft technique. And the third, follow 1.5 years. Firstly, in November 2022, 21. Okay. In November 22, a 21 years old male patient visited to a fractured ground or took 11 cord placed in football. Look at the picture. We can see the ground root fracture with the exposed sole of the palm. The fracture line is 1 millimeter above the labral gingiva, and the fracture line is 1 millimeter below the distal and palatal breastbone. So the panoramic X-ray shows the radial occlusion line in the cervical 1/3 of the tooth and fracture 1 millimeter below the distal breastbone. On CBCT, we find the following information. The fracture line oblique from the labral to the palatal side, 1 millimeter below the palatal breastbone, and the labral bone was is intact and more than 1 millimeter in thickness, and there is no epicolation. So, firstly, the patient not come to me. The patient come to my clinic with general dentic, and after evaluate the X-ray and examination, she planned a conservative approach for the patient. Root canal treatment, round lengthening surgery, and a HC fragment retractment of post and core with restoration. And the patient had a single visit root canal treatment in November 2022. This image for the 5 days, you can see the tooth appears stable in its original position and the gingiva is healthy. But 3 weeks later, the patient make a follow-up appointment, so he come again with the fracture. The fragment become detached. At this time, he were very nervous and he no longer want receive quickly treatment plan, and he seek a comprehensive, fast and long-term solution for both aesthetic and functionality. So, because he have a plan to study abroad, so the general dentist referred the patient to me for the implant resuscitation. So, which solution is safe and optimal in terms of aesthetic and treatment time? Normally, we have to approach to handle this condition. The first is the original plan for the patient. The second, delay implant, and the third, immediate implant placement with provisional crown. And based on the patient need, I indicate immediate implant placement for the patient because this plan reserve the gum and bone tissue, especially gingival papilla, and with a high success rate in many references. So I believe that this may not be the best solution, but this is the most optimal one, the optimal one. And I choose protocol according to Tano and Stephen Chu concept for this case. This is a Taiwan socket, so the implant position is dry, as you can see in the pictures. In my case, the implant is placed 3 to 4 millimeters from the mid-facial, placed slightly to the palatal aspect, and placed with apical anchorage to the hard bone wall of the nasal palatal canal to increase primary stability. Based on the bone dimension of 9 millimeters in buccal palatal, so I selected a noble RT implant with a diameter of 4.3 millimeters and a length of 13 millimeters. The next step, I fabricate the provisional crown for the patient with on the cylinder with composite, and I choose the center graft for grafting in the bone zone. This is the protocol for fabricate provisional crown. Based on the protocol and clinical examination, I evaluate the advantage and disadvantage as follows. So, as you can see here in my ROSI, here in my treatment plan step by step. Now I will show you. The first step is root extraction using a traumatic tooth extraction technique. This is short video about the process. After that, I perform implant placement. I place the implant after checking the depth of implant. I tighten the implant to achieve initial stability of 60 Newton centimeter. After that, I perform the immediate provisional crown. Here are the steps of making the provisional crown as follows. And look at the back after finish fabricate the provisional crown. Look at the back socket. We can observe a gap of more than 2 millimeters between the implant and the labor bone wall. I use IPF to create a sticky bone and filling it into a gap and condense it. And after that, I place provisional crown. I utilize the LPRF to support the tissue zone. Here are the results after implant placement and provisional crown. As you can see, the crown covers the extraction socket. The implant through hole is located at the cingulum position. The occlusion is adjusted to avoid contact. The post-operative paragraph shows a favorable implant orientation, correct provisional crown placement, and the temporary crown is no contact with the breastbone. On CBCT confirms the implant position matching to the initial design. 3-month follow-up, we can see a good healing soft tissue and also integration around the implant. So I received the taking digital impression. This is fine. After placing a customized abutment, I observe a thin label gingival phenotype and adjust the buccal contour accordingly to enhance soft tissue volume. As you can see, a buccal gingival contour seems thinner, and The central incisor display relatively uniform shape and color. The gingival margins are even overall and through retained ground. The periapical film confirms a tight fit between the restoration and the implant. 5 months after placing the restoration, the patient has oral hygiene and had gingivitis on the distal side of tooth 11. The periapical film show no abnormality, so I indicate scaling and schedule of follow-up appointment for the patient. In May 2024, the patient returned looking very happy and cheerful in his face, as you can see in picture. However, during examination, I noted a lesion on the buccal gingiva located 1 millimeter from the gingival machine. I believe that this lesion is caused by soft tissue irrigation due to slowly soft xenograft bone. So, especially in the thin phenotype gingiva, bone graft particles are trying to exfoliate through the soft tissue. Afterward, I took an X-ray to exclude the lesion originating from the bone tissue, and of course, we found no abnormality on CBCT. And based on a similar case study in the book, The Single Tooth by Tanau and Stephen Chu, which discern a soft tissue irrigation due to slow resorption of graft bone. So I performed incision to remove the contents of the lesion. And after 1 week, although the gingival response to the treatment, it remained red and slightly swollen. And you can see a deficient soft tissue contour on side of 11. So I indicate a connective tissue graft to enhance aesthetic and implant protection. First, I create a tunnel flap above the alveolar crest using partial technique flap. Then I collect the graft, stabilize the graft, adjust the buccal contour to enhance soft tissue volume, and after that, play the restoration again. This is the picture follow-up at 4 weeks. As you can see, the soft tissue has become firmer with a similar color to surrounding gingival, suggesting graft tissue integration, and the gingival margins of incisor are aligned at the same level. The gingival thicker than before grafting. Continue follow-ups at 6 weeks. After 6 weeks, the soft tissue around the implant healed well, with color matching to the surrounding gingiva. Finally, this therapy brings a natural and confident smile to the patient. Here are the treatment outcomes. 2022, the patient come with a fractured crown of tooth 11 below the gingiva. 2024, tooth 11 has been restored with an implant, achieve good aesthetic and function. In summary, immediate implant placement with immediate provision of crown may be a visible treatment option for cases requiring earlier restoration of teeth to be attractive. And connective tissue grafting have increased soft tissue volume around the implant and achieve optimal aesthetic. Besides technical conclusion, correctly planning the treatment is extremely important, and effectively communicating the plan to the patient and obtaining their consent are crucial factors for success. So, The best plan is the plan that the patient understand clearly and cooperate with. And this all for my case. Thanks for your attention.
Recording stopped.
Thank you for your presentation. The judges, any comments?
Well, thank you for your presentation. It's an interesting case with a lot of stages, so it was nice. And well, I want to congratulate you for the participation. Okay, so thank you very much.
Yeah, thank you very much.
Nicely done. Excellent slides. The slides are really nice. Photography is very well done. A lot of nice media as well. Even with the difficulty at the start, which would make a lot of people nervous, you held your composure the entire time. So congratulations to you.
Okay, thank you.
Hello there, MEGA'MIND 2024. Nice to meet you here, all judges and the MINEC team. So I'm Ongart from Thailand. So I'm the prosthodontist. So I work in the private hospital and the faculty hospital. So in the implant workflow, my part is the prosthetic part. So today I'd like to share my experience about the topic is about the striving beyond the comfort zone in the anterior implant challenging cases. So if we talk about the anterior implant challenges, we know that this is an aesthetic zone that we expect the display of the tooth shape, the tooth color and contour and the shape and the transparency. So in many cases of the implant placement in this area, we find some difficulty about the depth and the angulation of the implant in the anterior zone. So as a prosthodontist, what we expect in the implant prosthesis is like an aesthetic, is like a retrievability and the strength of the prosthesis. Nowadays, we have an innovation as the ASC, or that stands for the angulated screw channel that help to change the screw axis opening from the labial size to the palatal side or the lingual size. But what is an interesting question is what is a proper abutment that we should select for the ASC and in this kind of case? And today I'd like to share the points of concern of each individual cases. So the aesthetic zone, the typical bone structure we call it is a procline maxillary or alveolar bone. That maybe come from some anatomical limitation, such as the different proclination of bone and the different root angulation. So when we place the implant, well, we need to concern about the angulation and the depth, such as in this case, our patient have their labial bone loss. So when we place the implants were placed palatally at the apical area for their primary stability reason. But unfortunately, the improper implant position and the angulation can be result from the bone limitation as we see. And if we talk about the ideal 3D implant position or 3D, if we see about the mesiodistal, we know the distance from the implant to implant is 3 millimeters, and implant to the adjacent teeth is 1.5 to 2. About the buccolingual or labiopalatal, the labial bone we expect at least for 1.8 to 2 millimeters, and lingual bone is 1 to 2. Somehow, the colonal apical aspect, the number is 3 to 4 millimeters from the implant platform to the gingival margin of the final restoration. So what an interesting point of the coronal apical or the depth of the implant in each cases. For the number 3 to 4 below the CEJ of the adjacent teeth or the gingival margin of the implant restoration, the purpose is for allow the adequate room for the emergence profile that we can create it for the aesthetic reason. One scientific paper that published in 2023 from Stephen Chen and team talk about the comfort zone and the danger zone. So when we see the coronal apically aspect, we see that the number 3 to 4 millimeters in the middle picture. If you go beyond that, it will go into the red zone or danger zone. And if you go below that number, maybe the implant is too shallow, or it's difficult to create the good emergence profile. So in this scientific paper, mentioned about a deeply placed implant is a common complication with the immediate implant placement. And for myself opinion, I said at the severe bone loss area, without the bone augmentation or the surgeon unable to do the good bone augmentation, the implant can go very deeply. Such as in this case, is an immediate implant placement in the tooth area 1-3. After extraction, they put the surgeon put the implant. And as the Dr. Stephen Chen mentioned, this is usually associated with their attempt to achieve the primary stability by driving the implant deeper in the osteotomy. So we see that in the deep implant, these advantages, including the difficult implantation for the prosthodontist as me, and very painful for the crown insertion. And you need to use the customized abutment that increasing the course of the treatment and the post-operative pain from the bone compression. So in the aesthetic zone, today we like to talk about the depth and the angulation. So this is my case report. Thai female, 22 years old with a non-systemic disease. Her chief complaint is about the upper anterior bridge have gap and the spacing, and she feel pain sometimes, and the spacing at the lower anterior as well. So when I take a look at their intraoral examination, we find that from tooth number 12221 is a PFM or porcelain fused to metal bridge, have a leakage margin and gap from gingival recession. And tooth number 21 had pain and positive to their percussion, and the lower teeth from 3.2 to 4.2 have a spacing. So I take the X-ray and find out tooth number 21 have the PDL widening at the apical area. So this case diagnosis is like an improper processes of the 1.2 to 2.1 area, and 2.1 that have pain, we diagnosis as the irreversible pulpitis with a chronic apical periodontitis. So the lower teeth have spacing. When we take a look closer, we find out the big problem or the pain point of this case is the spacing. The patient would like to eliminate or change it, and they have pain at their front teeth, tooth number 21. So my treatment plan is we need to remove the bridge at their 1.2 to 2.1 area, and 2.1 need the endodontic treatment with a prefabricated post. And after that, I will make a crown to separate called like 1.2 and 2.1. And for the lower teeth, we plan for the ceramic veneers, and 1.1 we plan for the implant and the crown. So after remove the bridge and the root canal treatment, the temporal bridge was delivered, and the ceramic veneer at the tooth number 3.2 to 4.2 was done. And then my surgeon placed the implant at the 1.1 area with the GBR. And for the specification of their implant that we use is Strawman BLT, bone level taper, with the size of their diameter 4.1 millimeters. So after 6 months, we remove the temporal bridge, and I am the prosthodontist who finding that the healing abutment that the surgeon used is like a 5 millimeter height. But with that height, I still, in the picture, we see that it's partially submerged and tilted at the labial area. And when we see the X-ray, I measure from the computer, we find that it is 5 millimeters when measured from the bone to the implant platform. So it's not a normal situation as we concern at the first glance. So after I remove the temporary bridge and put the impression coping insertion and take the X-ray, we find some interesting number in this case compared with the normal depth in the ideal position like 3 to 4. We find that the distance from the platform of implant to the CJ or gingival margin of a restoration is go up to 7 millimeters, and 4.7 millimeters is the area in the subcrestal. So we can define that this case is like a too deep implant in coronal apical aspect. So about the abutment selection that I use, because the angulation of the implant that tilts, and we need to adjust the screw opening axis. So the type of abutment that I choose is a variable base, AS. AS stands for the angle solution for the crown. So the diameter for front teeth, I select the 3.5 millimeters diameter. And unfortunately, this system provides us only 1 millimeter cuff height. So when I take impression and send to the lab, and when the crown and abutment come back to me, this is the first try in, I faced the problem that is unable to insert the abutment and the crown. The question is why? What happened? So I recognize that, okay, it's come from two mistakes. The first mistake is come from the surgeon. The depth of the implant is too deep, with the surrounding bone is an obstacle. As a prosthodontist, I see myself mistake that I designed for the too large of the circumferential crown at the subcrestal area, and the inadequate communication with their technician. So we just know that the technician didn't know where is the bone in the stone model. So the solution is send the information of X-ray to the technician and discuss with them to solve this problem of their too large or of the diameter of circumferential abutment. So this video showed that how deep of the implant is in the stone model. So the orange line that I draw it for my technician is like and this cut with the product expert. I define it like an hourglass shape, yeah, to reduce the size of the diameter. So in this case, I still use the same variable as AS abutment, but with the slimmer zirconia abutment with the respect of the bones surrounding that as an obstacle to correct the angle and deep implant position. So this is the second crown and abutment that we changed the design and the diameter of the zirconia in the stone model. And this is in the intraoral picture with the X-ray. So this is the picture intraoral that I take from the patient, from the side, and from the front wheel. So this is a picture before and after. So the pain point of this case was corrected with their closer space, and patient feel more comfortable and more confident with their veneers and the crown on the natural tooth and the crown on the implant. So the point of concern when I see that the first crown and abutment, when they dissected of the first crown, I noticed something about the thickness. So the thickness of the zirconia abutment at the subcostal area is less than 0.5. So the question is, this is an adequate strength or not? With the new zirconia crown, that is slimmer. Slimmer is mean thinner. So the thickness of that area, it should be less than 0.3 millimeters. I have one experience in one case that in this case, 2-1 and 2-2 missing tooth with just only one implant that placed in the 2-1 position with a cantilever pontic. 1 year of use later, patient come back with the fracture of the zirconia abutment crown at the subcostal area because it is a thin ring around the thigh base abutment, AS abutment. So about the discussion part about the aesthetic zone, when deep and angulation is a challenging issue, what abutment and retentive type of the implant crown is an ideal? For the ASC or angulated screw channel, we have two abutment type that we can use in the market. First is the pre-mill or the titanium CAD/CAM milling. The second one is a thigh-base AS. That the MEGA'MIND have like a RC-based abutment, and with the Straumann in this case is like an AS abutment. So compare with their thigh-base and zirconia abutment and the titanium CAD/CAM that anodized. About the price, the thigh-base and the zirconia abutment in Thailand is more expensive than the anodized titanium pre-mill. Aesthetics is almost the same. If you talk about the strength, some question about the thigh-base and zirconia abutment in some situation, such as in this scientific paper of the Neoh in 2019. He do the seismic review in 2,231 study. He finds some 5 study report about the zirconia abutment fracture. So he said that zirconia abutment is very good for the aesthetic in the thin area of the like a phenotype, gingival phenotype, but take a risk of the mechanical complication. So he concluded that in the case of angulation, that more than the 20-degree anodized pre-mill titanium abutment should be preferred due to the better mechanical strength. So in the anterior area, the case selection is very important. And the other paper about Sakamoto, he mentioned this in 2018 about the limitation of the ASC with the thigh-base abutment. He see that insufficient space, especially in the zirconia abutment area, and the titanium metal that cause a grayish color in the thin soft tissue phenotype that in reduced ceramic thickness, like a weaken the crown and the abutment. So advantage of a pre-mill abutment in this kind of case is like you can, for the titanium, you can thin it with the proper strength with the less over-contouring of the crown, and for the adequate space for the soft tissue with the subgingially go up to 1 millimeters and to gain the maximum aesthetic. So this picture show the first and second, it used a thigh base with the zirconia coping on that show the flat transition compared with the titanium CAD/CAM that you can achieve the smooth transition for the implant platform to the zirconia coping. And if you add on the anodized to change the color, is more aesthetic in that case. So my conclusion is for striving beyond the comfort zone, in my case, the proper implant position and angulation should be planned to prevent the complicated fabrication. Abutment selection in deep and angulated implant position should be selected for the ASC abutment properly for the aesthetic, for the retrievability and mechanical strength. And the dentist and technician communication is very crucial to achieve the satisfactory. And this is my references. So I'd like to say thank you for your attention. And this is truly opening the opportunity for me to unlock my potential and test my mind about implant planning and implant treatment. The road to Cannes for me is like a daydreaming. It's like never been come true. I never been to Cannes before, but if you believe in me and you see that I have my potential, so please, thank you very much.
Recording stopped.
Okay, thank you for your presentation. So, judges, any comments?
It was good. Nice presentation, nice slides.
Thank you.
Overcoming the sharing the screen obstacle in the beginning didn't seem to phase you, so that was good. So lots of luck. You did very nice. So congratulations to you.
Thank you very much, sir. Dr.
Yeah.
Isaac, thank you.
Congratulations. It's a very nice case and a very good situation to explain how to solve the problems. And it was fantastic to have your participation. And we hope also that you get to France to the next level.
Thank
So
you very much.
Thank you.
Thank you. Nice
Okay.
to
Just a second. Yes. So, hello. First of all, I would really like to thank you, the team of MEGA'MIND and MINEC, for conducting this wonderful competition. I must say that it not only encourages the young clinicians, but it also bring those clinicians on a world stage together and share their novel ideas. So let's start this journey. Look at this beautiful structure shaped like a lotus. It is basically known for its Baha'in culture, and it is a religious structure which is known as Lotus Temple. Now, I would invite any one of you and to my city to show this beautiful structure and beautiful temple, rather. And I would say that this is my city, which is known as New Delhi, the capital of India.
So if you'd ask me that which part amazes me the most about Delhi, I would not mention anything about these famous historical monuments and the heritage sites. What amazes me the most is this. You can see that the road is jam-packed with the traffic, and there is not even an inch of space to move around. However, nobody gets late. Everybody is moving. Rather, this pick is the only thing which is stationary. So I would rather say that sometimes I feel that there is some quorum sensing is going on amongst all these vehicles to keep that understanding going on. So this, along with the amazing people of Delhi, makes it a beautiful city. And that is why it is called as, it is a popular saying that Delhi is not a part of India, it is rather a heart of India. So with that, I would like to introduce myself. I'm Dr. Manish RATHI. I'm a periodontist and implantologist. I've studied from the University of Delhi. And for the majority of my career, I have treated cases of, severe periodontitis in young as well as the old patients. And apart from that, my interest developed slowly in the perioplastic surgeries, including the root coverage procedures. Then apart from that, I had always that interest in developing the aesthetic implant look, or the we can always also say that it is aesthetic implant dentistry. So I would say that it was only last 2 years, 2 to 3 years, which brought a major change in my practice. So this was my peri-implant tissue that used to look like, maybe I would say 2 to 3 years ago. Then with gradual experience and skills, development of skills and knowledge, my peri-implant tissue started looking like this. And this is what I ended up in. With this, I was say that I'm still not very happy, but overall it gives me a sense of satisfaction, and with that in the anterior region. So with that, I will come on to my case study. Today, I'm going to present a case which has taught me in a way that how do you embrace your failures and learn from them. So this was a 28-year-old female which reported with this grossly decayed tooth. So if we go with the problem list, we can see a 4-6 decayed tooth with the grossly decayed crown structure. It was already endodontically treated. There was a periapical radiolucency with respect to the mesial root, as well as there was a communication with the furcation. Because of the direct communication, there was no tooth structure in the furcation region. There was a radiolucency in the furcation region as well. And when we see the crown structure, we can see there is a gingival recession known of Cairo RT1. And on CBCT, when we see, this was the periapical radiolucency, almost 2 to 3 mm away from the inferior canal, a 1.2 mm buccal cortical plate. But when we look into it, just see, we can see the root cause. It is the gutta percha which is extruding. And when we see the furcation bone, it looks like a bottleneck, which is, constricted in the apical region, but coronally it looks okay. So it has every chance of fracture when we go for an ideal prosthetically driven implant placement. So diagnosis was previously treated asymptomatic apical periodontitis, and there was the abscess formation as well, chronic apical abscess. So I went ahead with the SAC assessment, which resulted in a surgical classification of complex category. However, prosthodontic classification led into a simple category. The main point to consider were the availability of the apical bone to achieve the primary stability and the timing of the implant placement. So in a way, the SAC assessment was resulting in doing a delayed implant placement with either socket preservation for the time being. But I went ahead with the type 1A protocol after minimally invasive extraction. So when we see the literature regarding this, as stated by Hamilton, that dental implants are placed in fresh socket on the same day of the tooth extraction as part of the same procedure. The type 1A protocol has certain requirements, which includes the presence of the healthy adjacent tooth, intact facial bone. There shouldn't be any acute infection. We should be able to place the implant in correct 3D position, and there should be an anticipated stability of implant to allow the immediate restoration. With the study by Raguchi et al. In 2020, there was an implant survival rate for immediate implant was ranging from 94 to 96%, while the study conducted by Lang et al. In 2012 yielded that the immediate implants have got a success of 98.4% in the anterior region after a 2-year follow-up. So let's jump on to the surgical protocol. After doing minimally invasive extraction, we can see that the furcation bone looks good. Good here that we can go ahead with the implant placement. So a 5 by 10 mm of implant was placed into the socket successfully with good implant stability. And this is how after the immediate provisionalization, it looked like this. This is the radiographic view. We can see, in fact, here also we can see that a constricted furcation bone, interradicular bone, which was there. And this is after placement of implant and the immediate provisionalization. We can see that the jumping gap was filled up with the mix of xenograft and allograft, and it was the patient was kept on review after that. So this is how it looked after 5 months. During those 5 months, everything was extremely fine. There was a mild interdental inflammation because of the plaque accumulation, but otherwise, implant looked absolutely fine. So when I decided to give a final crown after 5 months, and using the scan body, the implant impression was taken, and a monolithic screw-retained zirconia restoration was delivered. So everything was fine till now. When I saw expecting the tissue like that, I got this. So something is odd here. Like, I won't say that it is absolutely, it looks infectious, but it doesn't look healthy as well. So while I was putting the torque on the screw, basically placing the crown over the implant came out after 5 months of implant insertion. So we can still see these bone graft particles which were evident in the socket. So what I got was the fake stability, and the initial stability was only because of the terminal 3 mm of the apical bone, which was not sufficient enough to hold the implant because the bone grafting was not helping the implant in this particular case. I went ahead with the histopathology examination of the sample, which I obtained from the socket. We can clearly see there is no new bone formation around the bone graft. It is just the lymphocytic infiltrate and some granulation tissue surrounding the bone graft particles. There is no new bone formation. So we went ahead for a second treatment protocol. For that, we need to state the problem list. Now we have no interradicular bone. We have no apical bone. Socket is compromised due to failed implant. There is no possibility of correct 3D implant placement. We got for reassessment, and now because of my heroism, the prosthodontic classification went to complex category. So there were few additional points which included, lack of vertical bone volume, proximity to vital anatomic structures, as well as the prosthetic volume. So the revised treatment plan included alveolar socket preservation using allograft versus the staged treatment, which included late implant placement with augmentation procedures, versus explain the risk to the patient and go for immediate again. So I tried to convince the patient for all three. Ultimately, we explained the risk to the patient and we went for immediate again. So This was the implant failure on the restorative day. I tried for, here I used MEGA'MIND Anyone implant system. I tried to gain the stability from apical bone to keep it, in the prosthetically driven position, but I was not getting any implant stability, which I got from the mesial wall only. When I was absolutely sure that the primary stability is enough, the socket was filled with PRF and the bone graft, which included only allograft. So this is how it looked post-operatively after giving the immediate provisionalization of the crown. And this is how it looked after giving the final restoration 6 months after, 4 months after the initial implant placement. And this is 6 months post-restorative. Here we can see the implant. There is a good band of keratinized tissue we can see around the crown. The crown was monolithic zirconia, polished subgingivally using the ultra-polished subgingivally using the Ceraglazed burrs, and everything was fine. This is after 1 year. Now, most important thing is we can see here there is a lack of interdental papilla, which got subsequently filled. And we have a nice, healthy peri-implant tissue and no loss of buccal contour in this particular case. Now comes the interesting part. When you see here, here is that hazy kind of bone, which was just 6 months post-restoratively, and now it started corticalizing. You can see the cortical bone in the crestal region, which is corticalizing, and we can very well say that it looks like a healthy bone, very mature bone. So there is bone gain on the mesial aspect above implant platform as well, and bone gain on distal platform covering the first thread. What was more amazing was the 24 months post-operative. Look at the mature cortical bone after 12 months. And after 24 months, even the first thread is covered. It reached the implant platform, and both mesial and distal aspect have the healthy, mature cortical bone. So this was my case. I followed in all these cases the zero bone loss concepts because I came in contact with Professor Thomas Linkevicius. So the major factors which I consider in my implant dentistry practice as keeping the conical connection of the implant. Then apart from that, I use at least, I make sure that I have some 3 mm of vertical soft tissue thickness, because the vertical soft tissue thickness is really important for the implant success. Platform switching is must, and I need to have a screw retained tie-based restoration and subgingival ultra-polished zirconia, which is approximately 48 nanometer as stated by Professor Linkevicius. So to conclude, I would like to say that failure isn't just opposite of the success, it's just the part of life. Like in this particular case, I could have gone for a safer way, but I learned something new in this particular case due to my failure only. But trying again and achieving success is an art of life. So with that, I would like to thank you all once again for the patient hearing, and I really hope you liked my presentation. Thank you so much.
Recording stopped.
Okay, thank you for your presentation. So any comments?
Yes, it's not easy to show failures, but it's very nice to see that you could display that and then show how you overcame it. I think a lot of people can learn from that. Very often we see on the big stages only successes and only beautiful things. And a lot of times it's not real world dentistry, and this is very real world dentistry and a nice case to display, and you did it very nicely. Well done.
Thank you so much. Thank you so much.
Well, congratulations, Manish. Is interesting. I agree with Dr. Tawil. It's not easy to show failures, but it's part of life, as you say. So congratulations, and thank you for sharing your knowledge.
Thank you so much, Gonzalo. Thank you.
Okay, the result will be announced on 20.
So, good morning to all the audience. I would like to start by introducing myself. I am Dr. Yasir Ikram. I am a periodontist. I work in Pakistan. I will be showing a case of lateral sinus floor elevation in a patient who was a patient of chronic periodontitis. So the outline of my presentation will be as follows. I'll start with introduction, then a brief summary of the case, then the treatment plan, the surgical phase, the prosthetic phase, and the conclusion. I'll try to skim through because the data regarding this case, I have a lot of records, so I'll just go through the important ones. And sir, you can stop me in between wherever, I mean, you would want to see the detail, please. So this is the initial OPG versus the final OPG. My patient is a 37 years old general surgeon by profession who was working in the same hospital where I was doing my residency. The case was done in 2017, and now it is almost 7 years since the case was done. So my patient is a male married general surgeon, 38 years old by profession, who came to me with a chief complaint of that he cannot chew because of his pain in his upper posterior teeth. The teeth were also mobile. The medical history was insignificant, and the patient was ASA1. The patient has had various dental procedures done, and he was being seen by his local general dentist, and multiple times the scaling was done, and he had a few teeth that were lost due to periodontitis. The patient's father and mother both had a history of tooth loss after the teeth becoming loose, and the mother of the patient was also wearing a complete denture. So oral hygiene was, I mean, as for the patient, he would say that he would brush regularly and floss, but once you would see the condition, you would come to know that the oral hygiene was not really good. On BPE, the BPE scores of 4 out of 6 quadrants were 4. So the initial pre-treatment photographs, these are the extraoral photographs. On intraoral examination, you can see that the lips were competent. I mean, the mouth opening was normal, the facial symmetry was symmetrical, TMJ was normal. This is the intraoral picture in maximum intercuspation. Well, you can see that there is calculus and recession specifically on the palatal side of the upper molars. You can see the right and the left side. So on intraoral examination, there was heavy supra and subgingival calculus with staining. The soft tissue was inflamed and edematous. There were missing teeth and carious teeth, and there was spacing in between. So orthodontic evaluation was also done in case the patient opted for closing the spaces. Teeth mobility was present in tooth number 16, 17, 18, which are the upper right molars, and tooth number 26, 27, and 28. These were all grade 3 mobile. The full mouth plaque score was 76%, and bleeding score was 56%. So EPT, cold test, percussion, and palpation, all the examinations were done. This was the perio chart before the start of the treatment. Here you can see that there is extensive bone loss on the upper molars, both on the buccal, palatal, and the palatal side. There was mobility, and you can see that there was location involvement of almost all the molars. Similarly, on the lower teeth, rest was almost okay, but the lower left molar, you can see the percussion was involved. And if we look, the bone loss was extensive on the upper right molars, on the upper left molars, and the lower left molar was associated with a lesion which will explain more in the coming slides. So again, you can see on the periapicals, you can see that there is a lot of bone loss and a lesion is present on the lower left molar. Now, CBCT evaluation was done, and you can see that there was no bone present for the implant placement, and there was almost in existing orodental communication with thickening of the sinus membrane. Similarly, on the left side, you can again see that there is almost no bone present. And once we look at the lower left molar, you can see that there was a lesion associated with the molar. So I've arranged this slide just to correspond the radiograph with the clinical pictures, and then to show the perio charting in that area, just to have a correspondence. So this is the buccal area of the upper jaw. You can see that there is extensive bone loss. Then this is the palatal of the upper jaw. And again, you can see that there is extensive bone loss in the upper molars. Similarly, in the lower, you can see that there is extensive, there's a huge lesion associated with the lower molars. So the periodontal diagnosis was generalized periodontitis stage 4, grade C. The patient had severe periodontitis, and there was then the prognosis of each tooth was established using Maguire and Nunn's classification. The ones in the red were the teeth that are in the red were deemed as hopeless. So patient education and counseling was done. Everything was explained to the patient. I mean, we started off with managing the acute conditions, and different treatment options were presented to the patient, including the removable and fixed teeth, and the patient opted for fixed solutions. So treatment plan was conducted in a standard way. We started off with the emergency phase, then initial, then corrective phase, and then with the maintenance phase. So this was a complex case as per the surgical assessment by the SAC classification. Since we know that there was infected tissue all around, we started off with extraction of the molars. You can see there's calculus on the molars. After extraction, you can see this is 2 weeks post-op, the tissue is healing. 3 weeks after the initial presentation, we extracted the lower molar. There was a lesion, lower left molar. We grafted the site, the lesion, and after placing the graft, we placed a non-resorbable membrane that was left exposed. The purpose was to keep the vestibule and the soft tissue around the area. So this is 2 weeks after the placement of the membrane. You can see this is the picture taken at the time of suture removal. So since the patient was also on a perio maintenance, we called him back after 8 weeks. You can see that at 8 weeks, the upper left and right sides have healed, and the lower right side where we had grafted, we have got beautiful soft tissue around it. At the same time, we can see that in the lower incisor, lower right incisor, there's plaque accumulation. So again, the reevaluation was done, periodontist was done. Patient was explained, since he was a general surgeon, we had to tell him everything as per the evidence. These are the list of articles that I provided to my patient. He wanted to know everything in detail. He was an associate professor, so he wanted everything to be done in an evidence-backed manner. So we use the same CBCT for the sinus lift planning. These are the sites where we will go with the sinus lifting. Now, since the initial extraction of the teeth, we are almost 2.5 months forward. So CBCT, it is the standard of care. Now we do CBCT in all the patients where we have to do. And if someone wants to know the difference between CBCT and fan beam, this is an absolutely beautiful paper. I really love it. So my guidelines for sinus lift are these are from a beautiful book written by Dr. Jensen. Usually, if there's less than 3 millimeters of bone, I would go with 2-stage procedures with a lateral approach, and I'll wait for 6 months, place an implant, and then I will wait for 4 months, and then I'll restore. The first is the option that I opted for this patient. Then if I have a bone of 3 to 4 millimeters, I usually go with 1-stage approach with lateral sinus lift and simultaneous implant placement. Well, there are many other factors. We know that the type of floor, the angulation, the buccolingual angulation of the floor, the width of the floor of the sinus, and the mesiodistal angulation as well. So these are the guidelines that I've got from this book, and they have been really helpful in my clinical practice. So we started off with the left side. So you can see that a palatal incision was given, a flap was elevated, and after elevation of the flap, piezo surgical unit was used to create a window. Piezo is that in my practice, the schneiderian membrane is usually intact. These days, what I've done is that I usually go with the hybrid technique, where I remove the outer bone with the diamond burr, and then once I see the hue, I use the piezo unit to completely move the bony window away. So these are some of the advantages, that it's very safe. My prime goal of using a piezo is that it lessens the bleeding, and it is very safe for the soft tissue. Even if you touch the schneiderian membrane, there's chances that usually you'll not perforate it. So you can see that after creating a window, the schneiderian membrane is intact. So after lifting the schneiderian membrane, we used sticky bone, and allograft was used, and allograft was mixed with the growth factors, and then it was packed into the sinus membrane. You can see that we had packed a lot of bone. After placing and packing the bone, more bone was added. Let's see. After packing the bone into the sinus, The graft was covered with the with a resorbable collagen membrane, and then passive primary closure was achieved. Remote incision was given to keep the site away, to keep the incision away from the surgical site. This is 2 weeks post-op at the time of suture removal. The sinus instructions and the post-op medications were given to the patient. This is again a beautiful paper that guides me regarding the use of antibiotics in my sinus paper in patients that have bruised the sinus lift. So similarly, on the right side, again, piezo surgical unit was used to make the window. After creating the window, the sinus was elevated, the membrane was lifted, the membrane was intact. Again, sticky bone was used and it was packed on the right side as well. Again, you can see that the surgical area was first covered by the PRF membrane and then with the resorbable collagen membrane. And then passive primary closure was achieved on the right side as well. So you can see this is 2 weeks apart and the tissue is healing. So we had recession and the patient was always also complaining of sensitivity in the lower incisors. So we would plan that as well. So this is 6 months post-op. You can see that we have got almost 14 millimeters of vertical height. And we use this denture with a GP radiographic marker in it to just guide us. And these are a few of the sections that were used to just give us a reference for the placement of the implant. At the same time, I would just came through this, that the lower incisor area, we went with coronally advanced flap with connective tissue graft, since the patient was complaining of sensitivity. And at the same surgical visit, we also placed 2 implants. The surgical guide that was used was again that old analog style. This was in 2017 during my residency time. You can see that these are different pictures at 1 week, 2 weeks, and 4 weeks. And similarly, on the lower left area, the implant was placed. This is again 1 week, 2 weeks, and 4 weeks post-op. And you can see that this is the lower anterior area where the connective tissue graft was placed. You can again see the baseline 2 weeks and 4 weeks. Similarly, on the left side, on the right side where we had done the open sinus lift, the implant was placed. After placing the implant, apically repositioned flap was sutured in position. Again, being a periodontist, I always want to have a good keratinized tissue, although there are studies that say it is not important. I always like to have good keratinized tissue. The problem I had with the upper left area was, this is the 6th and implant in the 7th area. There was no vestibule depth and there was no attached tissue on the buccal of the implant. So I proceeded with a free gingival graft around the implant. Again, the thickness of the pellet was checked. Apically, tissue was placed apically and sutured. Deepithelialization was done. Graft was harvested from the pellet. You can see the graft was roughly 1.5 millimeters thick. So graft was sutured in position. Palatal protection plate at that time, at my time of residency, I would use to give this. And this is 2 weeks post-op and the patient reported for suture removal. You can see after the removal of suture at 2 weeks, this is the condition. And from here, we were able to go to here in the upper 6 and 7 area. So this is after the surgical phase, and then we went to the restorative phase. In Pakistan, we did not have that digital prosthetic at that time. So we went with the analog. Phase 4 records were taken, wax and everything. And PFM prosthesis was made, the instrumentable protocol was followed, and the prostheses were placed in position. Similarly, on the right side, the emergence, the screw access hole coming out of the occlusal area. So this was at the time of prosthesis placement. So since the patient was a patient of periodontitis, he was on a 6-monthly review. This is the 6-monthly review of the patient. As you can see, this was at 6 months. So this was 1 year follow-up in 2019. And this is 7-year follow-up, which was taken a week or 2 back. And we can see that there's a carious lesion present on the one of the teeth, and it will soon be either referred to endodontic specialist for the treatment. So this is my case. This is my department. These are all my fellows who I trained with. I would like to especially thank my mentor, Professor Kurramataullah, who helped me reach where I am. And he was the one who taught me everything. This is our department, Fatma Memorial Hospital in Lahore, Pakistan. And in the end, I would like to thank you, the Bites Institute and the MEGA'MIND judges and everyone who gave this opportunity to me to present my case.
Recording stopped.
Okay, thank you for your presentation. So, judges, any comments?
Good.
Sorry, I didn't
think
have the. Yeah. Sorry. Congratulations for your presentation. It is very interesting, everything that you have showed today, and thanks for
Thank you, sir.
participating. It's a MEGA'MIND. Thank
Yeah.
you.
Thank you.
Yeah, it was a very nice presentation. It's a lot of surgery on one patient to share in one case. It was nicely done. You had a lot of great techniques, and between sinus lifting and the connective tissue grafting, free gingival grafting, it's a lot to do to show, and you did it well. It's compacted to 15 minutes, so I know it's tough, but it was very nicely done. And congratulations.
Thank you very much, sir.
Hello, everyone. Thank you for joining us today. I'm so glad to see you all here for Continental League of MEGA'MIND 2024. My name is Miss Kannika Bureekanchan, graduated from Prince of Songkhla University, Thailand. Today, I will present an immediate implant placement in an infected socket site in aesthetic area. Let's get started. Thai female patient, 59-year-old. The patient came with chip complaint, tooth 21 porcelain filled to metal crown dislodgement, and tooth 11 gingival recession exposed crown margin. Patient denied any medical disease and drug allergy. There is no problem with previous dental treatment. When examining tooth, it was found that tooth 21 porcelain filled to metal crown dislodgement with metal post, central upper incisor supra-eruption, root surface exposed about 1 mm. Gingival recession, thick biotite, sensitive to percussion, no pus and exudate, and no tooth mobility. This picture shows upper central incisor poor prognosis for restorable. Unlike lower picture show radiolucent area between tooth 11 and 21. Floor panoramic film show good contrast, symmetrical condyle, present radiolucent area between tooth 11 and 21 in maxillary bone, no positive pathology in mandibular bone. From clinical examination and radiograph of upper central incisor, a differential diagnosis can be made as follows: 1. Radicular cyst, 2. Lateral radicular cyst, and 3. Nasopalatine duct cyst. However, a biopsy must be confirmed. Therefore, this can be summarized as follows: problems and diagnosis. For tooth 11, the problem with this tooth is supraeruption, gingival recession, tooth discoloration, and last periapical lesion. So the diagnosis of tooth 11 is unrestorable tooth and radicular cyst. And for tooth 21, the problem with this tooth is crown dislodgement, present rarefied area, tooth discoloration, and supraeruption. So the diagnosis of tooth 21 is unrestorable tooth. When trying to simulate the implant's dormant bone level taper diameter 4.1, length 14 mm on tooth 11, it was found that the implant engaged apical bone about 2 to 3 mm, with the implant platform position 4 mm from gingival margin where the final prosthesis. And tooth 21 also used an implant's dormant bone level taper diameter 4.1, length 14 mm too. It was found that the implant engaged apical bone about 6.49 mm. This picture also shows the final position of implants, tooth 11 and 21. A 2015 study by Shakanovic et al. Found that several studies support immediate implant placement of teeth with periapical lesion or periodontal disease can be successful in osseointegration. But before implantation, the socket must be debridement and cleaning the socket before implantation. This is consistent with a study by Puttipisitchet et al. In 2016 that found immediate implant placement for teeth present periapical lesion or periodontal disease. This can be done safely if the socket is cleaned well. And from a study by Puttipisitchet et al. In 2016 showed the survival rate of implant placement into infected site was 98.4% plus or minus 0.9%. In this case of tooth 11, it was found that apical implant engaged maxillary bone about 2 to 3 mm, which was unable to restore the provisional crown. Therefore, primary closure was needed, such as socket seal surgery. Nowadays, there are many types of material used for socket seals, including free gingival graft, collagen matrix, collagen sponge, acellular matrix, polytetrafluoroethylene membrane, and individualized healing abutment. Most recently, Fabro et al. In 2022 systematic review has suggested that socket seal surgery using soft tissue or various materials can reduce hard tissue chains better without socket seal surgery. At the same time, Kannika et al. In 2022 discovered that soft tissue graft preserve the horizontal lid better than other types of membranes. Free gingival graft is an option that is popular in making socket seal surgery because 1. Reduce shrinkage of the soft tissue architecture, 2. Addition soft tissue volume, and 3. Reduce the dimensional change. Therefore, a treatment plan with 3 options has been proposed for treating patients as follows. Option 1, radicular cyst enucleation with upper central incisor, immediate implant placement with socket sealed. The advantage are preserved IDP, short treatment time, patient satisfaction, and preserve hard and soft tissue. Option 2, radicular cyst enucleation with upper central incisor socket preservation and socket seal. The advantage are preserved hard and soft tissue. And option 3, radicular cyst enucleation and upper central incisor extraction for waiting early implant placement with GBR. So when talking with the patient choose option 1. Well, it's time for implant surgery. A traumatic teeth extraction with enucleation and socket debridement complete. No labial bone perforation. A biopsy from tooth 11 was sent for pathology examination. Both teeth immediate implant placement with gap grafting at tooth 21 and tooth 11 defect grafting with xenograft. Socket seal surgery with free gingival graft that harvest from the left palatal side. This picture shows immediate post-op of panoramic film. This picture shows immediate post-op of periapical film. And this picture shows immediate post-op of CBCT. After 3 days, you will observe that the free gingival graft is beginning to turn red, indicating a high likelihood of free gingival graft survival. Follow up 7 days, confirm that free gingival graft will definitely survive. While waiting for the disc-off, it was found that the biopsy results were known to be a lactic acid. Follow-up 14 days found that tooth 11 free gingival graft complete survive and tooth 21 partial necrosis in the central of free gingival graft. Follow-up 1 month. Follow-up 1.5 months. Follow-up 2 months. Follow-up 4 months. I start the second stage of surgery to get a provisional crown after implant placement for 6 months. This picture shows clinical and radiographic post-operative in 6 months. Panoramic film post-operative in 6 months. And CBCT post-operative in 6 months. For the flap design of stage 2, the design is paracrystal at tooth 11 and 21 area and vertical incision at tooth 11 mesial side and 21 mesial side. After that, I tried in temporary abutment of both teeth. And I designed for create distal papilla at tooth 11 distal side and 21 distal side by split finger flap. From the slide is where the white arrow point. After that, I suture the finger flap with gingiva at palatal area of tooth 11 and 21. This suture must be a butt joint technique. Until suture complete and temporary crown shown in this picture. I was total stitched off 2 weeks after 2 surgery. Waiting for the complete soft tissue healing for about 6 weeks, I made an appointment for the patient to final impression. I designed the final crown to be layering zirconia crown with very open abutment of tooth 21 and angle screw of tooth 11. After I removed the temporary crown, the soft tissue looked good, healthy, and ready for the final restoration. This picture shows follow-up 2 weeks after final crown delivery. Everything looks good. Follow-up 1 month. And follow-up 1 year after crown delivery, everything looks good. And this is a very long journey of this patient. She was very happy to have these both teeth. Conclusion: immediate implant placement in infected site. Advantages: 1. Reduce treatment time. Combine extraction and implant placement in 1 visit. 2. Preservation of bone and soft tissue. Maintain oral lid and gingival architecture. 3. Enhances aesthetics. Immediate implant placement can lead to better aesthetic outcome. And 4. Patient convenience. Fewer surgical procedure and shorter overall treatment duration. For disadvantages: 1. Higher risk of infection. Infected site may increase the risk of implant failure. 2. Complex surgical procedure require high surgical skill and precision. 3. Uncertain initial stability. Infection may affect the initial stability of the implant. And 4. Needs for antibiotic. Increased reliance on antibiotic to manage infection site. Thank you for your attention.
Recording stopped.
Okay, thank you for your presentation. So judges, any comments?
Yes, sure. That was a very interesting presentation, very nicely documented, and very challenging actually to get good stability on that case. That was I don't want to say heroic because it looked like you did it very nicely. It didn't look like you were being a hero. It looked like you were doing proper dentistry, but look very nice and excellent outcome. Nicely
you.
done.
Yes, it was a very extreme case, so I agree with Dr. Tawil. It's an excellent result after a lot of problems before. So excellent documentation and congratulations for the participation.
Yes,
Thank
congratulations. It was worth the wait. We're glad we had you back on.